Iboan, and a very good evening to all our viewers here on TV1. I'm Dr. Dilshan Fernando, and this is your weekly dose of wellness here on Healthline. Today we are in conversation with Dr. Shazar Hameed. He is a consultant orthopedic surgeon at the Provincial General Hospital in Badulla. And today we are going to be talking about one of the most important organs, I would say, in the body, the spine. And the spine, having many different functionalities in the body, is something that we should always be mindful about. And today we are going to be talking about what we call spinal disc prolapse, or in layman's terms, a slip disc. So, very good evening to you, sir, and thank you so much for joining us all the way from Badulla and gracing our studios today.
Good evening, Dilshan, and thank you very much for inviting me for this program.
So, first and foremost, sir, to get an introduction into the program. Now, we know everyone would have heard about the spine and this condition called slip disc, but for the intents and purposes of them understanding what we're talking about better, I think it's pertinent that we talk about the anatomy of the spine.
Yes, that's right, Dilshan. So, as an introduction, spinal disc prolapse is a very common condition. So, it's roughly estimated about 10% of the population would get affected by a disc prolapse at some point of their lives, and some may have symptoms, some may not have symptoms. And as we know, spine issues commonly give rise to back pain, and back pain is one of the most common symptoms people have. So, when we speak about the disc, I mean, we commonly speak about the discs, and we need to know a little bit of the anatomy and the sort of the structure of the spine. I've got a sort of a model of a spine. Now, let me show you. So, this is the lower half of the spine. In a colloquial term, you call it the spine, but the bony structure itself is called the vertebrae. So, you've got numerous vertebrae which are stacked up together to form the whole column, and in between them you've got what we call is the disc. So, the disc is predominantly composed of two parts. You've got a sort of a softer jelly like material which lies in the center, and a bit of a tougher layer which restrains that disc, which lies in the surrounding part. And if I may just turn it towards this way, along the whole length of the spine, you've got a sort of a canal. This is where our spinal cord occupies. This is the nerves of the spine, which at this level sort of is responsible for controlling the functions of your legs, your bladder, your bowel, and even your sexual functions. And at each different level you have, this is the side-on view, you have a couple of nerves each which come out of the level of each spine. Now, so what happens in a slip disc or disc prolapse is whatever the contained soft disc material within the center in this disc space bulges backwards. And at times it may be just a bulge, or it may sort of rupture the surrounding tough structure and protrude completely into the canal. By doing so, what they tend to do is they tend to compress on the nerves and give symptoms related to that. So, this is the brief anatomy and actually what happens in spinal disc prolapse. It's quite common in the lower half of the spine, which we in technical terms call the lumbar spine. Why these occurs is we may give certain answers because certain reasons may be the fact that your weight is transmitted across your whole length of the spine, and the discs being the weaker point may have sort of the strains which may cause the disc to bulge backwards. There may be so many reasons, some are recognized, some may not be recognized.
Right. So, now as Dr. Hameed went on to describe this spine contains of the bony structures and the gel-like structures in between, which I believe helps in absorbing these vibrations and helping the spine to be stable. So, as you mentioned, now this soft part bulges out and ultimately compresses the nerves coming out of these different levels. So, now when that happens, like you said, these nerves are involved in the functioning of the legs, the bladder movement, the bowel function, and also sexual functions as well. So apart from the pain, like you correctly said, what are the other symptoms that these patients might be experiencing?
To start with, they tend to have, a lot of them have back pain. So, the initial bulge itself may produce a lot of back pain, and your back muscles may go into a spasm along with that. So, you may have severe back pain. And since they are compressing on the nerves, and these nerves being the nerves which travel to your legs, they tend to have shooting leg pains along your leg. So, what we have noticed is most of the patients come and complain to you about back pains, but they do not think the leg pain is part of it. And when you cross examine them, and when you do specifically ask them, they say, yes, I have got the leg pain as well. So, in the West, we used to call it sciatica. Even it may even be considered as a medical term, because the nerves which are which come out of your spine at the lower level constitute a nerve called a sciatic nerve, which is very important to sort of controlling the functions of your leg. Along with that, the nerves are also important in controlling your sensations in the leg. So, the patients may complain of tingling sensation, pins or needles, or numbness, especially of your foot. And very rarely they can have even weakness of your feet especially. And they will say, or their relatives might have noticed, the patient is dragging his feet while he is walking, and may have difficulty in sort of walking and actually jogging or doing other activities. So, these are the sort of the neurological functions, we say, which the patient might experience. But again, other symptoms also sort of depend on the nature of the disc bulge. So, you may either have a small tiny disc bulge which is compressing on one particular nerve, or you may have a quite large disc which is sort of compressing the whole of your nerves, the whole bunch which is in the center. So, based on that, your symptoms may dictate upon the size of the nerve, and so is the urgency at attending to the problem.
Right. So, now the symptom profile that you described might be there in a certain degree in some patients, and some might have the full blown picture. Now, like you said, back pain might be one of the principal complaints. And now, for the intents and purposes of our discussion, so now when a patient comes to the back pain, I believe it's not only spinal disc prolapse which can give rise to back pain. So, how would you go about assessing these patients who come complaining of back pain? Because like we said, spinal disc prolapse is just one cause. It could be something much more sinister, or it could just be a small muscle strain as well. So, how do you assess these patients?
Yeah, that's a good question, Dilshan. So, so what the assessment is that roughly about 60 to 80% of the patients at some point of their life would have back pain. So, out of which I would say a very, very small percentage would be sinister, but it is always important to catch these sinister problems. So, we do not have an established system, but in the West, the GPs, the general practitioners, are sort of given a list of what we call red flags, red herrings, which are which can coexist with back pain, which are alarming and which would require urgent intervention from a specialist. So, one of the things which is important is the age of the patient. So, if somebody who is over 55 presents with long standing back pain, I will be a little bit more concerned, not alarmed, but a little bit concerned, and I would make sure that he is not having anything sinister. Because in that age group, cancers are quite common, and you may have problems of cancers originating within the spine itself, but more often cancers elsewhere spreading to the spine. Then again, if a patient has a history of cancer previously, and that would be quite alarming as well. And if you have back pain along your upper part of the spine, that is also a little bit alarming. Now, that is because of few reasons. So, the upper half of your back, we call it the thoracic back, it is part of your sort of the thoracic cage or the chest cage. Now, that is not a very flexible part of your spine. So, the flexible part of the spine is your lower half and the neck. So, the degeneration or wear and tear effects of the spine is more related to the parts which are in constant movement, which thoracic back is not. Secondly, more sinister causes like infection or cancer is a little more prevalent in the thoracic part of the back pain than the lumbar. So, this is another what we call as a red flag. And again, if you have significant pain which is really worse even at night, this is again another red flag. If you have conditions which will may throw you into infections where your immunity is low. For example, if you are having uncontrolled diabetes, or if you are on treatment to suppress your immunity, and if your nutrition level is quite low, especially people who use IV drugs, drug abusing. So, these are the circumstances where we think infection may be quite common.
So, when you say infection, it's the infection of the spinal cord?
Not just spinal cord, in this vertebra itself. So, okay. What happens is most of the time the bacteria or the organisms tend to commonly it starts to originate within the vertebral bone, and they may sometimes extend into the space where the nerves lie as well, or rarely they may start within the spinal canal as well. So, this is spinal infection. And we being in the subcontinent part of the world, tuberculosis is very common. So, we quite often find patients with tuberculous spinal disease as well. So, this is another. So, these are the red flags, and more importantly, if somebody comes with back pain and any neurological function, neurological symptoms like weakness of their legs, or if they have issues with their urinary functions or bowel functions, these are quite alarming features. So, these needs attention than the simple red flag, simple back pain. So, these are the rules by which we go usually to see whether the patient is having any sinister cause for his back pain or not.
Definitely, that's one reason why we have these kind of programs, so that you beloved viewers are aware of what these symptoms and signs might herald. So, definitely, as we always advise, if you do have these symptoms, especially like we discussed, back pain might be a very common symptom, especially amongst the elderly, but if it keeps going on and if it is associated with one or more of the symptoms that we discussed as the red flags, you definitely need to be followed up by a properly qualified medical practitioner for further follow up. It might not be something sinister, it might be something sinister, but always better and pertinent to get it checked out. So, moving along with our discussions, and now we spoke about the anatomy of the spine and what the possible causes giving rise to this back pain. So, now focusing on this spinal disc prolapse, are there any specific risk factors for a person to develop this, and how does it work?
Well, it doesn't always. So, they've seen that it occurs a little bit more commonly in males than the females. It is more prevalent in the age group of 30 to 50. So, these are the healthy young adults who indulge in probably heavy activities. So, the presumed one of the causes is like heavy manual activity, which may cause torsional strains at the level of the disc, and which may cause the disc to bulge out. They say it's a little bit less common in the elderly group because the disc itself undergoes a lot of structural changes and becomes a little bit stiffer with aging, and it is less susceptible to protrude or bulge or cause a disc prolapse. But nevertheless, we do see at that age as well. But you may run in quite frequently to patients who are not heavy lifters, who are not engaged in heavy manual activity, still end up coming with disc bulges. So, you cannot exactly say this might be a cause for it.
So, that's a very interesting fact that you bring out. So, because our viewers would expect all these problems in the spine to be more prevalent towards the elderly years of your age, but interestingly enough, spinal disc prolapse seems to be more common among the age of 30 to 50. Now, you mentioned about heavy lifting. So, now we see a culture where people are more aware and more concerned about their health, and we see a lot of people going to these gyms and all that, even we see the ladies doing some heavy lifting. So, does that mean that everyone who does these gym workouts or engage, let's say for their occupational purposes, or some engaged in heavy lifting, does it mean that just because you lift something heavy that you're prone towards getting this?
That is a good question, Dilshan. Not exactly. So I think there is the most important thing when you speak about the back related problem is the back discipline, the posture. So when we maintain an ill looking posture, all our weight is transmitted to the muscles surrounding rather than taking it from the legs. So it is important if you are engaged in weightlifting, gym activities which involved, to have proper instruction about how to do it, and there is always a right way of doing it and there is a wrong way of doing it. So if you have professional help who will teach you how to maintain your back when you lift a weight, how to start lifting, how to progressively increase your weight when you lift, so these are the most important things. So if you do it the right way, it's you may less frequently run into problems.
Definitely. Now, when a patient comes to you, we have discussed the symptom profile. So, a patient comes to you, says that he or she has back pain, pain radiating down the leg. What are the investigations that you would employ to come to a diagnosis, or do you straight away judge from their clinical presentation?
The first thing is, like, if you have some nerve related pain in the legs, and if you doubt that this patient is having a slip disc or a disc prolapse, the first thing I try to do is I just try to make sure that he doesn't have an emergency. So less frequently patients could have, as I told you before, quite a large disc which is compressing all your nerves. Now there is quite a technical term for it. We call it cord equina syndrome. So it means basically, the cord equina in Latin means like the horse's tail. So the terminal part of your spine is composed of a bunch of nerves which appears like a horse's tail. Now the importance of that is, within that nerves lies the nerves which control the sensation around your private parts, and more essentially your urinary, bowel and sexual functions. So it is quite vital for us to identify whether these people have symptoms related to these organs or not. So unless they have symptoms or signs suggestive of cord equina syndrome, if it's just merely sciatica they have, or a leg pain or a back pain, we should first identify where are they in their disease process. Because what is usually known is about 75% of the pain is relieved within about first 4 weeks. So at least about 75% of people, their pain substantially improves within 4 weeks.
That is spontaneously or with
spontaneously. So whatever the disc protrudes out gradually dissolves. So if that does dissolve, the pain subsides as well.
Okay.
Unfortunately, the best way of diagnosing a slip disc or disc prolapse is an MRI scan. As we know, it's a very expensive investigation,
and also not very freely available.
Not freely available. So not just in our country, even in the West. So that's the normal way. So we give at least about 4-week period for the patient, and during that period, it's not as if we don't do anything. We actively monitor and we give certain instructions, and we try to manage them conservatively that period. So if somebody, as I told you, about 20-25% of the people may have persistent symptoms even after 4 to 6 weeks. And this is the group, if you think they are really suffering, we can investigate and identify whether there is a slip disc or not. So we commonly do an MRI scan. So the MRI scan is helpful to first diagnose that there is a disc. And also, as I showed you with the spine before, there are so many levels of the discs. So we need to exactly know where the level of the disc
protrusion is.
And there are certain instances, some patients might not be able to undergo an MRI scan.
Such as?
Yes. For example, now MRI involves a magnetic field. So certain people may have sort of metallic devices which are not compatible with MRI scan within their body.
When you say metallic devices, these prostheses, like if they have had a knee replacement or hip replacement, or screws?
Certain implants we use in orthopedics.
Mm.
Most of the implants now in the modern countries are
Most of them
compatible,
come with cobalt, chrome or something
or
like that.
titanium.
Okay.
They are all MRI compatible, but still in our country we use stainless steels which are not compatible. But it depends on when you fix them. If you think they are quite fixed and fitted, they might not cause a lot of harm. But there are other things like clips which we use for aneurysms in the brain, and there are so many other devices which may cause harm.
So before an MRI, I believe all these things
Exactly.
are checked before a
Yeah.
patient goes in for an MRI. But for intents and purposes of our conversation, that's very important that our patients know this. If you have certain metallic implants,
Yes.
because you're going into a magnetic field inside the MRI, you might not be eligible for this investigation.
Yes. Usually the radiologists have a very strict protocol on who to put for an MRI scan. So we as the requesting doctors, we need to ensure we have a large questionnaire. We check patients regarding whether they have any contraindication to MRI scans, and once we fill in these questionnaires and the patients are again cross-checked at the MRI office itself to ensure that nothing is. So it's twofold. The most important thing is the patient safety. Then there is a risk of the equipment safety as well, which is a very important thing, because the equipment
Very
itself
costly,
is very costly.
equipment. And when we say contraindications for MRI, I think there's a very interesting condition because you're put into a hollow tube kind of thing, and you have to be there for a little bit of time.
Yes.
So can you describe a bit about
So
that?
that's claustrophobia. So
Yes.
certain people have fear, or they cannot tolerate closed environments, and it is quite disturbing because you might have to sort of spend about 45 minutes to 1 hour within the machine, and you hear strange noises, and people who have claustrophobia cannot tolerate it at all. Sometimes there may be the possibility of sedating under having an anesthetist beside and trying to do it, but certain group of people, if they're not eligible, they would not be able to go through MRI scans.
In that case, what is the alternative?
So there is the other method we call the CT myelogram. So it's basically a CT scan where the radiologist will introduce a certain dye to the surroundings of the nerves, and that is can be helpful to detect where the obstruction to the flow of the dye is. I mean the level of the disc prolapse, and it is reasonable, but it used to be a method which was utilized before, but with the advent of the MRI scans, we mostly involve the MRI scans now, and it is more an invasive procedure than the MRI scan. So we reserve it for people who are not eligible or who are not fit for an MRI scan.
So the gold standard investigation is MRI.
That's right.
So now once we do the MRI, we find out where the prolapse is and the degree of prolapse. What are the possible treatment modalities that we can offer?
Right. So the modalities are firstly, as we said before, we need to speak about before we speak about active invasive methods. What we do, we need to speak about the conservative measures as well. As I told you, a large majority, their symptoms subside within about 4 weeks. So during that period, what we request is, first thing is, it's very important for you to take very good pain medication. Now that is a misconception among people. They think if you take painkillers, that probably might the relief of pain may mask a more sinister thing within, which is not true. What we usually say is it may hurt you, but it may not harm you. So taking regular painkillers is very essential. The other misconception what people have is that you need to have prolonged rest. Actually, that is counterproductive. So the more you rest, the lesser your chance to get back into activity quite fast. What is now recommended is maximum of a day or 2 days of rest, and then to gradually get into their activities again, gradually.
When we say activities, we are talking about their day-to-day lifestyle, but
exactly.
what about the working out and doing manual labor?
That may have to stay a little bit longer. So, but walking, standing up, so not the prolonged bed rest, but you may get off the bed and you may stand and start walking gradually. Most of them benefit with a course of physiotherapy. Now, physios wouldn't usually advocate physiotherapy exercises at the time where the patient has acute severe pain. So, they also wait until the pain subsides to a certain degree. And then we can gradually start indulging into their normal day-to-day activity like walking, and with progressively, once the symptoms have resolved, after weeks to months, you can start even heavy lifting gradually. So that's a conservative measure. Now, at any point, you may seek intervention from your doctors as well if the symptoms are getting worse. And so the intervention again depends on the severity of the condition as well. Now, as I said, now this route of trying to manage somebody with the conservative measures and then going to injections or surgeries are for people who have sort of a less sinister condition. Now, if somebody does come with, I need to speak a little bit about cauda-equina syndrome. So, it's a very, very distressing condition.
And it's an emergency, like
it is an emergency. It is an emergency. Now, it is quite rare. Now, what's thought is it occurs in roughly about 10 to 12 people per million population. It's very rare. But it also occurs due to a disc. And discs are quite common, so we need to identify which one of them has the symptoms.
Because that patient would need urgent intervention.
Urgent intervention. Because what happens in cauda-equina syndrome, as I said before, this massive disc will compress not just the nerves which travel to your legs, but also the nerves which supplies your bladder, bowel and urinary function. So, there are certain questions we directly ask from the patient, for example, with relation to your urinary habits, whether they have the urge to pass urine. So, the people who don't have the bladder sensation, they keep on filling the bladder and they don't know whether their bladder is filled or not, and whether they can feel the passage of urine and whether they have any control of their urine passage. And importantly, whether they had any accidents like any passage, any episodes where they have passed urine without their knowledge. Same applies with their bowel function as well. So, if they have anything related to this, it is likely to be an emergency. I also do what we call is a bladder scan in this patient. It's a simple ultrasound scan. You do it in two different instances. First, when the patient has an urge to pass urine, that we call is a pre-void scan. So, the importance of that is generally we need to have bladder sensation at a usual volume of urine. But if somebody has a bladder volume of about 700, 800,000 milliliters, but still they don't have the urge to pass urine, okay, that's when the trouble has begun. Then the next scan is we ask them to pass urine and then do another scan, which is called a post-void scan.
So, you see how much urine they have passed.
Exactly, that's right. So, the rough cutoff we say is 100 milliliters. If you have less than 100 milliliters, we are happy, but if you are having more than 100 milliliters, that signifies something. And importantly, we examine them and we have no way of assessing a person's urinary retention ability. Now, the important thing is the urine tract and your bowel has what we call is a sphincter, what we call is something like a valve, which is under our conscious control, which enables us to pass urine or open our bowel at a time which is convenient to us. So, we can't check the valves in the urinary tract, so commonly we check the valve in the bowel and check the tone of the sphincter or the valve of the anus. So, if we have these doubts and if we think if even there is a remote possibility that it could be cauda-equina syndrome, we have to rush the patient to get an MRI scan and diagnose. Now, it is quite time dependent, Dilshan. So, once you have a prolapse, though physically we don't see an injury to the nerve, there can be microscopic damages to the nerve and its function. Now, it can be reversed provided that we intervene quite fast and swiftly. So, that is why I said it's time dependent. So, that is why from the time you diagnose, we need to get an urgent MRI scan, and once we see a large disc in the MRI scan, the patient has to go to the operating theatre.
So, that's an indication for urgent surgery.
That is indication for urgent surgery. So, the quicker you intervene, the more chances that we have
that you
for
preserve
this.
the functions of the spinal cord. Yeah. So, if you don't intervene in a timely manner, is there a risk that they might not recover their functions of the spinal, the whatever nerves that is involved?
Unfortunately, yes. Especially we are worried about the bladder and bowel functions. So, if you lose your bladder functions, you may end up with a permanent catheter, or if you lose your bowel function, there's risk of you soiling yourself also. It's very distressing. And if it happens in a very young adult, you can imagine his plight. So
definitely. No, like Dr. Shazar Hameed says, that's one very undesirable complication of a possible spinal disc prolapse, which a massive disc prolapse going and compressing all these structures there, which leads to what we call the cord equine syndrome. So, if you have the back pain, pain radiated down your legs, along with possible, not losing control over your bladder functions and your bowel functions and certain sexual functions, which will be decided by your consultant, not by yourself, but it advocates urgent attention from a medical practitioner. So, sir, now we spoke about this cord equine syndrome, and we were talking about these possible modalities of treatment.
Yes.
We spoke about how we can give pain relief, wait for about 4 weeks, but as it progresses along the way, and if they don't have an emergency situation, then what do we do?
So, we wait out for about 4 weeks, and if you think the patient still has significant symptoms, which is really debilitating, and then we get an MRI scan. So, if you do have a disc, the options we have is either we can give an injection or we can go for surgery. Now, there are pros and cons of both these. So, let me just speak about the injections.
Yes.
Now, there are two forms of injections we give. First thing is called the epidural injection, which means you give a medication to the space surrounding all the nerves, and hopefully it will act on the nerve which is compressed as well and give you pain relief. The second one is called the foraminal injection or nerve root block, where you inject to the vicinity of the nerve which is compressed or which is affected. That is done under either X-ray guidance in the theatre, or sometimes it can be done under CT, guided by the CT scan as well. Now, it is a minimally invasive procedure. It takes about quite a few minutes only, and you don't need to have a full-blown anesthetic. Sometimes I prefer to give a mild sedative or something to just make you rest and
calm
just calm the nerves,
yeah.
Which makes the injection procedure easy for us as well.
Yeah, otherwise the patient might be a bit restless. And you won't be able to localize the required, it's a very sensitive and specific injection, I believe.
That's right. So, having a sedative is a bit easy, but still all in all you can do it as a day case procedure.
So, these injections are all for pain relief?
So, what it merely causes pain relief. So, I told you the natural progression of the disc is it has to resolve by itself most of the time. So, what we are trying to do is give a pain relief and buy some time until the actual disc does get resolved. So, we generally give a combination of sort of a local anesthetic agent, which gives you sort of a short lasting pain relief, and a steroid, and hopefully buy some time until this resolves. Now, from the outcome point of view, most of the patients who receive injections, we have noticed that they have initial pain-free period, but some of them the pain tend to relapse back again. So, it depends on how long you had these symptoms, the pain relief period for. Based on that, we can decide if the pain recurs back again. There are certain, being a very minimally invasive procedure, not a lot of risks, but sometimes the patients may experience a bit of a worsening of their pain after about 24-48 hours. It's because the medication we inject tends to irritate the nerve a little bit. I advise the patients that it is it's a self-limiting condition. It tends to last for about 24 hours and it resolves.
So basically it gets worse before it gets better.
Sometimes, not in all the patients. So I advise the patient that there is this possibility, and if you do encounter, don't worry. And quite rarely, sometimes you may damage the coverings of the spinal cord, and as we know, the spinal cord and the nerves are sort of bathed in a solution or a liquid which we call cerebrospinal fluid. So it may leak out, and sometimes persistent leaking may give you sort of a headache. Now you have a sort of a tightly titrated amount of fluid surrounding the spinal cord, and if you have any and it's in continuity with the brain. So if you have any deficiency of that fluid, you may experience as headaches. Generally it is also self-limiting. We rarely see these occasions with injections. So those are some risk factors with that. But all in all, as it's a day case, the patient can get himself admitted on a day and get the injection, and we just monitor him for about a couple of hours. If everything's fine, he can go home. So it's a easy procedure. But we always advise the patient that there is a high possibility of his pain recurring back again.
Now, apart from this injection, we spoke about surgery.
Yeah.
Now, when it comes to spine, it's a very scary thought of undergoing some form of surgery of the spine. So, what is this surgery, and what can a patient expect during the operation, and most importantly, post-operatively, can they get back to their normal lifestyle soon, or do they require a longer period of rehabilitation and rest? How does that work?
Yeah, it's a very important thing. Like now, when it comes to spinal surgery, what we have encountered, especially in our country, is there's a quite large amount of fear surrounding spinal surgery. And when you ask them why, they say, there's a high risk of paralysis. Now, these are all because of what we call, I'll explain before we conclude, things called yellow flags. That is, patients tend to have fears and beliefs which are sometimes influenced by their friends or community, and this is one of them, is the fact that spinal surgery, any form of spinal surgery, has a very high risk of paralysis. To be honest, the risk of paralysis is extremely low. It's somewhere in the range of about 0.2%, and it's very extremely uncommon. So, I mean, you have any surgery is with its risk,
yes,
but complete full-blown paralysis of a leg is extremely rare. But less frequency, you can have other complications. So, from a surgical point of view, what we do is we do a surgery called a microdiscectomy. So, it basically involves to go through your back surgery, and as the name refers, it's micro, which means we try to operate with a very tiny incision. If it's a single level disc, your incision in the back, the cut may be maximum of about 2.5 to 3 inches. We use microscopes to make sure that we identify the tiny nerves, and it's we minimally disturb the structures at the back to fish out the disc which has come from outside. So when we do refer or advise patients about surgery, we tell them about the outcomes and its complications. So I have told you the high possibility of pain recurring with injection. In contrast, what we have noticed is, what the studies say is that about 75% of the patients who have surgery for disc prolapse have complete resolution of the symptoms, and yet another about 20% would have substantial reduction of their pain and will have some minor niggles. About roughly 5% of them would have no pain relief at all, and about 1% may have worsening of their symptoms. So we are speaking somewhere in the range of about 95% success rate. So for any procedure, if there is a 95%,
that's a very good success rate. So, but not all patients are offered surgery, as we discussed. So after surgery, what can they expect? Do they have to be in bed for a long time, and do they need to undergo physiotherapy?
Not exactly. So the techniques which we utilize for these surgeries, you are not causing any instability of the spine. So we try to stand them up with the aid of the physios and walk immediately as
This
soon
is
as possible.
immediately after surgery?
Immediately, even on the day of the surgery, if they can tolerate the pain, but definitely the next day. And wherever I operate the patients, I get the physios to teach them, physiotherapists to teach them how to roll over and get out of the bed, how to stand up, to make sure that you give minimum weight to your back, and how to walk, and especially they need to even take the stairs before they go home. And then we ensure that they go to the pass urine properly, and they have adequate urine passage, and they've got good control over it. And more often than not, after this surgery, we can discharge the patient on the very next day. So from a rehabilitation point of view, I ask them to keep walking. We advise them not to sit for prolonged duration for more than 20-30 minutes. That causes a lot of strain into your back and back muscles. Remember, whatever the small incision may be, we still have cut and gone through the muscle, and if you put too much of strain into it, it's undesirable. And even traveling, what I've advised is, if you are traveling long distance, when they go back home, I say, if you're traveling long distance, stop your vehicles once in 20-30 minutes, get out of the car or van or whatever, and just walk about and then get back to the vehicle. And after about 4 to 6 weeks, generally even after about 6 weeks, you can start gentle jogging, swimming. These are desirable. Returning back to work depends on what type of work you are involved in. If it's sort of a not so laboring activity, if it's an office type of job, you may get back to work even in about 4 to 6 weeks. But any heavy lifting, manual activity, ideally you need to stay for at least about 4 to 6 months, based on our evaluation.
Now, after surgery, one of the dreaded complications is people might think, can this recur? Can we get another disc prolapse? Do we have to go through this ordeal again? So, what are the chances of that happening?
So, there is a recurrence rate of again 10%. So, that is same as what you and me can have.
A person who hasn't
had a disc.
Okay.
So, remember now, the frequent question they ask me is, doctor, why, if you have taken the disc off, why should we get the disc back again? Few reasons. We don't take the entire disc, we only take the bulged out or the disc which has protruded into your canal. And the disc is essential, the rest of the disc has to be there. And
because
then
it serves a certain very important
so
function.
That's right.
Spine.
And now again, there are discs in so many different levels.
So, but another disc can prolapse.
Exactly. So, the surgery per se does not increase your risk of having another disc prolapse. You carry the same risk as a person who has not had a disc prolapse. So, that's the recurrence. Even if you do have a recurrent disc prolapse, the option would be the plan of management would be just like what I mentioned before.
Right. Now, with these conditions which give rise to chronic pain, there is one question that I need to ask. Some patients, without being followed up by the doctor, they tend to take this pain medication for a long period of time without going back for the follow-up visit. With that tendency, what are the possible complications that can happen?
So, there are certain patients, why they tend to do this is because of what I mentioned before, is their beliefs and fears.
Fear of intervention.
Now, we speak a lot about something called yellow flags. So, these are all based on that. So, they are influenced on what others tell them. For example, I mentioned one before, the fact that pain medication. Some people take medication, some people do not, and a fear of having surgery. And fear of going into paralysis, and certain people have issues related to workman compensation where they work, and psychosocial issues. You may have element of depression. So, all these negatively influence, and these people have a tendency of having chronic symptoms. We have identified, and going into chronic disability. So, these are again, when we examine, when we speak to patients, we try to identify these things, and sometimes these yellow flags may need intervention and addressing, just like your physical symptoms as well.
Definitely. Now, as we discussed in depth, medicine and the technology around it has advanced in leaps and bounds. So, and the doctor involved will only make a decision for an intervention weighing the pros and cons only if the benefits outweigh the risk. So, if you have any of these symptoms that we discussed today, it is very pertinent that you get attention from a properly qualified medical practitioner and follow the regime that they advocate. Go for your follow up visits, undergo the investigations, and if and only if necessary they will intervene for a surgery, and in that case also, like we heard, it is not too much of a complicated procedure. You might be able to go home the very next day itself, and the risks, the complications involved are minimal. So, with the time constraints that we have, sir, we are coming towards the end of this episode of Healthline. Before we wind up, what is your take home message to our viewers with regards to what we discussed today? What are the important things that they should bear in mind?
The important thing is to have a sort of a positive mind frame about what we spoke about it. The fact that having back pain is a common symptom, and then the symptoms and signs we described about, to just have an idea about what these alarming features are. And whenever is required, to get medical attention as early as possible, so that you know what you have and the fact that you've been followed up and you're in the right path.
Right. So, I think we had a very informative and in-depth discussion about slip disc or spinal disc prolapse, which is quite common in our society, and I think you, our viewers, would have benefited from what we spoke about today. So, we thank Dr. Shazar Hameed very much. It was a pleasure having you, sir, and thank you very much for gracing our studios today.
Thank you very much, Gihan.
So, with that, we wrap up this edition of Healthline. Until we meet you again next week with your weekly dose of wellness, this is me, Dr. Dilshan Fernando, signing off, wishing all our viewers Aibowan.